Doctor, we are online.
Thank you. Maybe can you flash the screen as well? Priya, can you please upload the screen as well?
One.
Should we begin?
Yes, doctor, we are live.
Thank you. Hello to our global audience and good morning to our lovely audience joining us from the UK. Guten Tag, hola, and good noon to our audience joining us from Germany, Spain, South Africa, and namaste to our audience joining us from India. On behalf of 26,000 plus members of Dr. Reddy's family globally, I welcome you all to this patient education webinar with top migraine experts from around the world. I, Dr. Supreet Singh, am part of Dr. Reddy's Laboratories family and based out of India. I lead the medical and clinical strategy for Dr. Reddy's. I'll be moderating this webinar for next 60 minutes. And with the help of our global experts, I'm pretty sure that the next 60 minutes are going to help thousands and thousands of migraine patients around the world to better manage their migraines by better understanding what they go through during their migraines. And since women are the most commonly impacted with migraine, it becomes important to understand the impact of migraine on women's health. So during the course of this discussion, we'll also learn a little bit about the role of new drug-free solutions, drugs such as neuromodulation in treatment of migraine, and especially women across different age groups and clinical conditions. Next slide, please. Dr. Reddy's Laboratories is a multinational pharma company based out of Hyderabad, the central part of India. The company was founded in the year 1984 by Dr. K. Anji Reddy, who was doctorate in chemical engineering. Right from the outset, he realized that if medicines had to serve their purpose, they had to be affordable and accessible. I'm proud to be part of Dr. Reddy's Laboratories as a company which has been serving humankind from last 40 years. Next slide, please. Our purpose is to accelerate the access to affordable and innovative medicines because we truly believe good health can't wait. Empathy and dynamism are the two principles with which these 26,000 plus Dr. Reddy's employees work to deliver on our promises. Our values are core to our day-to-day operations at Dr. Reddy's. Some of our key values include integrity and transparency, safety, quality of our products, productivity, respect for the individual, collaboration and teamwork, uh, and most importantly, sustainability. We will create value for our stakeholders in a manner that respects our natural environment and serves the best interests of the community in which we live and work. Today, we are also joined by our experts. And before I introduce the experts, we are also joined by two of our panelists to represent patient voices. They have volunteered to share their personal stories about migraine. We thank them for their willingness to share their journeys with all of us and deeply appreciate their thoughtfulness. I'm thankful to our global experts to spare their time out on their Sunday and agreeing to partner with us to improve awareness about migraine and help patients better manage it. Their participation today is testimony to their commitments to fight against migraine and help millions of migraine patients across the world. Once again, on behalf of 26,000 members of Dr. Reddy's family, I would like to thank them for taking their time out. It is my privilege to introduce them. Next slide, please. Joining us from Germany, we are thankful to Dr. Charlie Gaul. He's a board certified specialist in neurology, pain therapy, and intensive care medicine. He studied his medicine in Munich and Heidelberg in Germany. He's a research fellow for facial pain and headache at University of Zurich, Switzerland. He did his training at the University Hospital of Erlangen in Germany. His main interests include migraine, medication overuse headache, multidisciplinary therapy, facial pain, cluster headache, and clinical studies. He's member of several prestigious national and international pain and headache societies, working closely with patient organizations. Thank you so much to Dr. Gaul for joining us. Next slide, please. So we are also joined by Dr. Debashish Chaudhary from India. Dr. Chaudhary is the Director and Professor of Neurology at GB Pant Institute of Postgraduate Medical Education and Research at New Delhi. He is also the current president of prestigious Indian Academy of Neurology. His current headache research focus is on understanding trigeminal autonomic cephalgias, comorbidities, and risk associations in migraine and cognitive functioning in migraine. He's a top-notch researcher with several scientific research articles published in various journals and books. Being a convener to the headache section of Indian Academy of Neurology, he is a torchbearer in India with respect to the kind of advocacy work that Dr. Chaudhary has undertaken in the field of migraine to serve more than 240 million migrainias in India. We are thankful to Dr. Chaudhary to take his time out, and his health is not well, but still his presence on this platform is testimonial to the service that he intends to do for several migrainias in India. Next slide, please. Joining us from South Africa is Dr. Michael Huth. Dr. Huth is the president of South African Headache Society and member of the Education Committee of the International Headache Society. He completed his neurology training in 2014 and is a prestigious awardee of Sigo Nielsen Memorial Prize in the year 2012. Dr. Huth is also the director of the Board of Executive Committee of Neurological Association of South Africa. Welcome, Dr. Huth, to this webinar. Next slide, please. Joining us from Spain is Dr. Patricia Pozo Rosich. She's not only an avid researcher in the field of headaches, but a tremendous leader as well. At Vela de Hebron University Hospital in Spain, she heads the section of neurology department, Migraine Adaptive Brain Center, and Headache Research Laboratory. She is awardee to the several prestigious awards in the field of headache research, and those awards are testimony to her commitment to battle migraine by understanding them better. As an eminent researcher, she has published more than 180 research articles and 30 chapters in the scientific books. She is also on the editorial panel of several prestigious scientific journals. We would like to welcome Dr. Patricia Pozorosich to this webinar. Next slide, please. It is my utmost privilege to introduce Professor Peter James Goadsby, a mentor to lucky few, but an inspiration to all of us. Dr. Goadsby is the director at NIHR King's Clinical Research Facility. He's the professor of neurology at King's College London. He's an honorary consultant neurologist at King's College Hospital and Hospital for Sick Children. He's also the professor emeritus of neurology at the University of California, Los Angeles. Dr. Goadsby's pioneering work spread across an illustrious career has meant that we are in an era where we have started to improve our understanding about migraine. And he, along with his colleagues, has shown the way to several scientists across the world to develop several medicines to help improve lives of million migrainias across the world. Dr. Goadsby received his training from University of New South Wales, Australia. He did his postdoctoral work in New York, Paris, and postgraduate neurology training at Queen's Square, London. He's author to 500 plus research articles, part of several guideline committees, which has helped other neurologists to improve their practice patterns in migraine, and discoverer of several pathways in migraine on which we have novel medications. It is my privilege to introduce and welcome Dr. Goadsby here for this webinar. Now, what we are going to do next is, maybe if you can stop sharing. So what we're going to do next is we'll go over to our panelists for a round of panel discussion, where we intend to discuss several important topics for this. And to do that, maybe if I go first to Dr. Charlie Gaul. And Dr. Gaul, let me begin with you first. And for the audience, what should they understand about migraine? Are all headaches migraine? We know that there are more than 1 billion migraine patients in the world. How can people recognize if they have migraine, and when should they consult a physician?
Yeah, thank for inviting me here to give some thoughts to the auditory. I think a lot of migraine patients know it from the family history. They saw their mother or grandmother mother with headaches, and they accepted it sometimes at something is normal in their family, and they don't recognize that they can do anything against. And that's important that they understand it's not only headache. For if you talk to the patients with migraine, they will tell you migraine is more than just a headache. Migraine is accompanied by uh, other symptoms like sensitivity to light and noise, nausea, sometimes vomiting. They need a rest in a dark room, and they feel that the pain, which is usually intense, increase much if they are in physical activities, and therefore they lost a lot of their lifetime if they have frequent attacks. And therefore, to consult a physician because of headaches, which you know, for me, there are three main reasons. The first is if the patients have no good therapy for the acute attacks. They suffer from pain and the nausea, and they can't do anything against because the over-the-counter medication, which is still used by a lot of patients and is still working for a lot of patients, but they had no benefit from it in some of them, and then they need acute treatment. And the other point is if they have an increased frequency, for example, once a week or more, then they need a prophylactic treatment, which can be a drug-based or neuromodulation or with physical activity and relaxation training. And so they have to find a way how to manage their migraine self. And the third point is if the headache changes significant. Some people have migraine for all of their life and they know really good their attacks, but then another headache comes, something's changed. And then they should go to the medical doctor to not oversee a secondary headache. So there's an underlying brain disorder which may cause these headaches.
Okay, thank you so much, Dr. Kaul, for your thoughts with the audience. And maybe for the next question, if I may go over to Dr. Chaudhary. Dr. Chaudhary, India perhaps has the most number of migraine patients in the world. We have estimated 240 million plus migraine patients of different age groups.
Right.
First of all, I would like to salute you for your spirit with which you're working day and night to help several migrainias in India, which has such a humongous burden of migraine. With around 2 in 3 migraine patients being women, can you explain us why migraine is more common among women? For women's health perspective, what are the challenges involved in managing migraine across different age groups with the currently available treatment options?
Yeah, I think that that's a very basic and fundamental question. And I think that has bothered the researchers over the last half a century, that why women are more predisposed to migraine. And there is a very large number of sizable data that suggests that possibly the first important factor is hormonal in nature, right? Like, in women's life, the estrogen and the progesterone has got a cyclic kind of an up and down. And as the post-luteal phase comes and the estrogen level drops, the women are getting more predisposed to migraine attacks. So you have this, the strong menstrual association with migraine. And, you have two sets of people where the migraineurs have increased frequency and duration of their headaches during the perimenstrual phase, the start of the menstruation, initial few days. And also there are a group of patients, though rare, that they will have exclusively the migraine attacks during the menstrual period. So these are hormone related, and these hormones have that effect both from the genetic and non-genetic basis. The genetic basis are basically having their effect on the receptors in the brain, which are sensitive to the progesterone and estrogen, and they act to affect and modulate the pain pathways. And the second part is the non-genetic ones, because these hormones have an indirect influence about the vessel wall, on the vessel itself. They can have a vasodilatation, constriction, that modulation can also happen because of this, kind of hormonal changes. And also, it has been shown by the research that among the migraineurs in females, there is not only this change, but the change happens very rapidly during the later phase of the menstruation. So this change may be as fast as 30% drop compared to a non-migraine female patients. And that probably an important trigger for migraine for them. So that is one. Number two is that there is a lot of epigenetic mechanisms that play a role in modulating this hormonal and the pain pathway circuits. And we don't know much about this. We are just beginning to understand that how, for example, stress relates to this. For example, how the food habits relates to this. Fasting, sleep deprivation affects this. So all these factors also may have a profound effect and epigenetically modify the genetic effect of these mediators. And also it is important to know that, after the puberty, the women actually go up in the scale. Before puberty, the males and females, the boys and girls have more or less equal prevalence of migraine. But as the puberty happens, the women take over. And the rise comes in the third decade, but from the second decade onwards, this actually rise is very evident. And that goes on till about 50 years or 55 years. And then there is again a rise during the menopause, and then followed by a slowdown. So this pattern actually suggests that women, we don't know entirely about this conundrum, that why exactly happens it like that. There is a lot of research going on, but it is definitely that it is affecting the most productive period in women's life, when she is going to have her education, she is going to work, she is going to be having a family, and she has to take care of the family. So it's a tremendous stress on women during this period, and unfortunately, they are more predisposed to it.
I see. Thank you so much, Dr. Chaudhary, for sharing your thoughts here with our audience. I see several of our audiences have joined us on the YouTube page. Maybe for the next topic, I think people would be a lot more interested to hear, does the migraine only impact during the attack, or is there an impact in between the migraine episodes as well? And to understand this, maybe if we go over to Dr. Pozo Rosesh. Dr. Rosesh, you're a pioneer researcher in yourself in the field of headache, and have spent several years understanding what happens to the brain before, during, and after the migraine attack. We are at a stage where we are developing a relatively well improved understanding about migraine. I mean, if we look at a history a little bit, there are records that suggest Hippocrates and Galen, until 200 ADs, they used to believe that migraines were caused by vapors rising from their stomach. Leaping forward to 1600s, we had the first enunciation of vascular theory, suggesting that blood vessels in the brain dilate and enlarge during the migraine episode. Tell us, what are your thoughts? Does migraine impact the brain during the attack only, or does the migraine also impact the brain in between the attacks? And if so, then for the audience, can you help them understand what is the impact on immediate, midterm, and long-term consequences of migraine on brain health or activity? Over to you, Dr. Pozo Rosesh.
Well, thank you for the invitation. As Dr. Gal was mentioning, it's a pleasure to be here with you and share some thoughts on migraine. It's always fun and interesting, I think, to be able to increase awareness and educate. We always say that if you understand how the migraine really happens, you probably will understand how the brain almost works and our bodies, because migraine is such a complex disorder that it is it's not easy to probably put all of the pieces of the puzzle that we know about together, but we are getting to know many of these pieces in the puzzle. So we're already much better now than some time ago. And I'll try to answer this challenging question with certain data that might help listeners understand how their brain and bodies almost work. The first concept is that, as Dr. Gal was mentioning, migraine is an inherited disease in most of our patients. Many can tell us that their mothers or fathers, their parents or grandparents had already migraine. So part of the knowledge that that we know about migraine leads to genetics. And it was also mentioned the word even epigenetics. So we have a genetic background that predisposes an individual to suffer from migraine attacks, which are episodic and recurrent in time. That predisposition, if we study the genetics, tells us that migraine is fundamentally a neurovascular disorder. You mentioned both words. So yes, it's about the brain, but it's also about the arteries, the vessels that are kind of, the vessels that stem out of the heart and bring blood to all of our organisms, so our bodies. So how this brain works and how the vessels are, fundamentally, probably already at baseline are different in those who suffer or are predisposed to suffer from migraine than those who aren't. So in between attacks, individuals who have a trend, so a predisposition to suffer from migraine, are different. Then once we have that data, we go into how that brain and that body works. And what do we know? We know that in the migraine brain, in the individual who suffer from migraine, when we actually kind of try to understand the functioning of this brain, we see several things. The first one is that it is a very hyperexcitable brain. This means that with a patient or a person who suffers from migraine at baseline, intercritically, in between attacks, responds to a lower threshold. This means that they are more sensitive to stimuli, any type of stimulus. So whether the lights, the sounds, the smells, everything bothers them more already in between attacks, and that is even heightened. So it increases during attacks, and everyone who listens, I'm sure, will be able to relate to that. This, we believe, it's because this brain is so active. Maybe it's also, you can see it just because there's more excitability or because there is a lower possibility to stop processes. Sometimes I try to translate this by saying that it is like if this brain were able to open many programs in a computer, but not be able to close them. So at the end, you have too many programs, happening at the same time, and the brain suddenly needs to slow down and stop, which is what happens during an attack. The different phases, we call them, so moments of migraine in between attacks and during attacks, have been also extensively studied. Also, for example, by Professor Goldsby here in this webinar today, with also neuroimaging. And we have seen and been able to map how the activity in the different phases of migraine changes, is dynamic, and moves throughout the brain, telling us that, yes, the hypothalamus or certain parts of the brain, the thalamus, the cortex, are very important and active, you could say, depending on the moment where the attack is happening. So the brain is active, the vessels are active too. Yes, I forgot to tell you a little about the vessels, and just, I think that as you were already mentioning, we have started a new era, a new moment in our disease, you could say, in our field, because we have been able to start defining and describing migraine at a biological molecular way. We have been able, with some of Professor Goldsby's work, for example, to actually categorize the type of molecules, the peptides, the proteins, that change and are fluctuating during also these migraine cycles. And that has grounded the disease to biologically, which I think is very important, because it actually, yes, I'm not saying that it takes it out of this kind of invisible state of pain and symptoms that happen in migraine, but it grounds it to something biological and something that is treatable, or at least treatable for many. And it has opened up ways of understanding or trying to understand the disease very differently. And finally, you were mentioning about the impact of migraine at a short or a mid and long term. What would I say quickly about that? And if not, we can go back if there are any questions. I would say that migraine fundamentally, conceptually, impacts the individual, the person who suffers from it in all of these concepts, short, mid, and long term. But because it's so impactful, because it really conditions your way of how you're going to anticipate to pain, to attacks, not being able to know when they're going to happen actually makes you reprogram your life with a lot of anxiety that surrounds it. So life is impacted for sure by migraine. But is our brain, is our biology also impacted by the disease? And we have data nowadays that shows that as the more migraine attacks you have, the more frequent they become. So when that happens, there are changes that can be at least measured in the brain, and that and how in the brain anatomically, but also how the brain functions. So structure and function change. Clearly change when you have very frequent or chronic, what we call chronic migraine. The question here is how reversible this is with treatment, and we still don't have enough data to say or prove whether if in every individual this is reversible or not. We do know, however, that with age, in some people, at least migraine attacks improve a little bit. But there's still a lot to do research on, especially, as I was saying, to try and find out longitudinally. This means following the same person during their life to see how the brain changes in the disease. Hopefully, and just one sentence to finish, hopefully, chronic migraine or very frequent migraine or very disabling migraine, will not happen in the future. My personal goal for the next 5 years in the field would be to try and prevent, so not allow chronic migraine or very frequent migraine to happen. And hopefully with all of the treatments and that we have now in our hands, we will be able to at least do that for many people.
Thank you, Dr. Pozzolossi. I think what differentiates human from several other species is that hope, and the hope to
exactly.
and do better. With this, I would go over to Dr. Goadsby. And Dr. Goadsby, thanks to your pioneering work in the field of headache and migraine, you along with your colleagues have discovered few important biological mechanisms that trigger a migraine attack. The last 2 decades have seen the discovery of several novel targets which are used by drugs to help migraine patients improve their episodes. Thankfully, now, with the advancements in technology, we also have some of the novel modalities or approaches with which we can target the specific nerves which have either known to be playing a role in migraine mechanisms or target inhibitory pathways in the brain to treat and prevent migraine. What are your thoughts on these drug-free solutions such as neuromodulation devices? What all different neuromodulation approaches are available for patients to help them better manage their migraines?
Well, thank you, Dr. Singh, for asking me to be involved in this education web-based meeting. It's a pleasure to join you and patients online and my colleagues. As Dr. Gall said, migraine is more than a headache. And it's certainly more common in females, as Dr. Chowdhury explained the hormonal basis for this. And migraine biology is complex, certainly involves the brain, as Patricia Pozzolossi just said. Not everyone responds to the medicines we have. And indeed, we don't know why some don't. Patricia Pozzolossi is working on things like biomarkers, ways to define patient groups and understand who might respond. And it can be very frustrating for patients, even with these new medicines. Now, some particular things to think about with neuromodulation devices. What are they? They're approaches that change the way the brain functions to improve migraine. And there are a range of options for these, and they're obviously drug-free. The range of options varies depending on what country you're in, from stimulation of the brain using transcranial across the brain, magnetic stimulation, remote electrical neuromodulation device that that's placed on the arm, non-invasive vagus nerve, a nerve that runs in the neck stimulation, supraorbital nerve stimulation, occipital nerve stimulation, or a combination of supraorbital and occipital nerve stimulation. They all have particular advantages and different levels of evidence. So the first obvious difference between neuromodulation approaches and medicines is there are no drug-drug interactions. These are a range of things that can happen. The simplest, most obvious one for women is with oral contraceptives, and there are medicines that we use for migraine that can interact with those and change their metabolism, change the levels, and then you can't predict whether the contraceptive will be effective. So getting rid of drug interactions is important. Side effects are really important. People have to live with the disorder, and it doesn't help if they have to live with the side effects of medicines. And whether that's the side effects of attack treatments, nausea, chest discomfort, perhaps for some people worsening of their headache for the attack treatments, or more problematically, probably preventive treatments, things like weight gain, tiredness, dry mouth, cognitive thinking dysfunction, exercise intolerance, a whole range of things. And I'm sure all the patients on the webinar will recognize some of those things that complicate their migraine and then can be more complicated by medicine interactions. None of those side effects you see with neuromodulation approaches, very simply because they don't produce any of those sort of side effects. An obvious one of the advantages of the drug-free treatment environment is in pregnancy. Now, the devices are variously cleared or not cleared and variously regarded in pregnancy. I think we can say pretty clearly that for transcranial magnetic stimulation, there's really very good data, and it comes from MRI, the brain scanning technique to look inside the brain, which is an investigation technique, because it uses the same type of energy that transcranial magnetic stimulation does. And there's a very nice publication in JAMA several years ago, almost a decade ago, that looked at information from more than 1 million deliveries to show that really MR is safe in pregnancy. There's data from remote electrical neuromodulation, a paper that our American colleagues published a few years ago on 171 women who completed, who were identified, and 140 who actually finished the study, and there were no adverse outcomes in pregnancy. Nothing is perfect in life, but neuromodulation offers a way to treat migraine without much of the baggage that comes with medicines. That's not to trash medicines, but simply to say that, as my colleagues have said, migraine's common. Many people are affected, mostly women, and we need a range of treatments that suit people, suit women in all the stages of their life.
Definitely. Thank you, Dr. Coatsby. And these approaches bring in their own value added, and these are armamentarium to a neurologist. But if you were to think about one of the other value proposition of neuromodulation approaches is this dual benefits, right? They can be used for treatment as well as prevention. What do you think? How helpful are these from dual benefits point of view? I mean, earlier you used to have patients ask them to use specific type of drugs when they have a headache episode, and then tell them not to use it afterwards until you have the next episode. And then there are other set of drugs which you would ask them to take irrespective whether or not you had headache or not, doesn't matter, right? So now there are novel mechanisms that are available. CGRPs are one, and then neuromodulations are another ones, right? What are your thoughts on these dual benefits being offered by these neuromodulation approaches?
Well, the advantage of dual benefits is you only need one thing to do both the treatment of the attack and the prevention of attacks. The distinct advantage of that is you know what you're getting in terms of side effects and in terms of efficacy. There's a simplicity to it. And as you say, that applies across both the CGRPs, the small molecule CGRPs, and it applies to neuromodulation. I think that many patients find that convenient, not having to have a cupboard full of things, so to speak, to treat their attacks.
I see. Thank you so much, Dr. Coatsby, for sharing your thoughts with our audience. We go over to Dr. Huth, and subsequently now in this panel discussion, we'll pick up specific segment across different age groups, and then maybe Dr. Huth, starting with you, as one of our panelists earlier mentioned that migraine impacts patients across different age groups. There have been reports of migraine impacting as early as 7 months of age. Now, in children and adolescents, headaches cause a substantial impact on quality of life, limiting their social activities, physical activity, and school absenteeism. How common it is to have a migraine impacting children? And as a physician, how challenging do you find treating an adolescent migraine patient, especially around puberty?
Hi, good afternoon, and thanks for having me on and inviting me. It's a privilege to address everybody today. It's a really good question you asked, Dr. Singh. The prevalence of migraine amongst children, the audience might be quite surprised, can be up to 10%. At puberty, there's an increased incidence. Before puberty, we see that migraine really affects males and females almost equally. But once the hormones of puberty kick in, as was said before, the female hormones of estrogen and progesterone have lots of genetic and epigenetic effects on the nervous system. And so what occurs then is that females suddenly predominate in terms of migraine. And really, it's a significant health concern for the pediatric population. In terms of symptoms, young children can have symptoms that are quite different to adults. They may have even headaches that are of shorter duration, not the typical over 4 hours that are in classifications. And they may have vomiting, more vomiting than adults would have, as opposed to just nausea. And they can have also strange atypical symptoms, such as the classic abdominal migraine symptoms, which can present with a whole host of abdominal symptoms and often be misdiagnosed in that age group as a gastrointestinal problem, when in fact it's migraine. Irritability, all kinds of sort of behavior changes. So one really has to have a low threshold for thinking about migraine in a young child who often can't articulate their problems and their symptoms, etc., in any type of episodic cluster of symptoms that occurs in this age group. Problem with migraine is that it impacts and disrupts school attendance as well as school performance. Makes it difficult for the child to concentrate often. They also can't participate in after-school activities, extramural activities, sport, or other types of activities, and it affects their social life. And of course, social life is a very, very important part of childhood and adolescence. Migraine comes along with lots of comorbidities, and some of those comorbidities, such as anxiety and depression, are much more prevalent in children that have migraine as those that don't have migraine. Children can often feel a bit isolated or frustrated by their condition. And that's a problem that needs to be addressed in a very holistic way by the healthcare provider. So it's really crucial to make an early diagnosis in a child, to make a correct diagnosis, and to address their migraines as best as you can in terms of identifying triggers and developing a management plan, both with lifestyle and, if necessary, with medications. And then incorporating holistically the support from the school, the teachers, the family, and getting them to be educated to understand, creating an environment for the child where they can actually function, because you just don't want them to get into this vicious cycle of, lack of school attendance, poor school performance, more stress on the child, more exacerbation treating of the migraines, and then just get into this vicious cycle where they get deconditioned. You really don't want that. You want them to be functional. You want them to show up and really to take the power back from their migraines, empower themselves. Long-term outlook is that if you treat migraines early and you get on top of them early in childhood, you have a very good chance of them being also controlled in adulthood. But if you don't do that and they get out of control, you get into that sensitization and the whole idea of migraine begets migraine and what we were talking about earlier in some of the talks, then it can be problematic in adulthood. Some children may even outgrow migraine, especially if they're probably more males than females, that would be. So that's a possibility, but a lot of females will go on to experience them into adulthood and really maybe only have resolution after menopause. So one has to be really, really vigilant in terms of this age group.
I see. And what are your thoughts regarding potential benefits of drug-free solutions such as neuromodulation for this particular very sensitive age group?
Well, like Professor Goldsby alluded to, all those reasons, when we look at a treatment anywhere in medicine, we look at risk versus benefit. And when you can minimize the risk, then you really put yourself as a clinician and as a patient in such a good box or zone for treatment, because now we're just worried about, well, will the patient benefit? And really with neuromodulation, most of these devices are non-invasive. They are really very quickly applied. So what happens is that you can have, for example, in adolescence or childhood, it's very suitable for a kind of school setting or a social setting. Like they could take it along with them to a birthday party. And if they need to, some of the devices are quite discreet. For example, there's one that goes on the arm that can be placed under the clothing, and some that can be used, for a short period of time, quickly, without drawing too much attention to the patient. As has been said before, there's fewer side effects, there's no drug-drug interactions, and it really gives the patient a sense of empowerment and control over their migraine management. That can boost their confidence and help them take more of an active role in their health, which is very important. We find also that a lot of young patients, we live in a tech world, and a lot of young patients love technology. They love devices over an old school medication. You don't want the patient to come back and say to you, well, I see, why did you prescribe me an anti-epileptic? I'm not an epileptic. Or why did you prescribe me an antidepressant? I'm not depressed, etc. You don't want to have that conversation on an ongoing basis. The patients love when they get a device. It links to their cell phone. They can use a high-tech, expensive device somewhere on their body, and it's much more acceptable to them than taking a medication and having to deal with all that goes around, all the stigma of taking medications.
I see. Thank you so much, Dr. Huth. Now, maybe if we go back to Dr. Debashish Chaudhary to understand the impact of migraine on quality of life and social integration, particularly for a young adult patient. Dr. Chaudhary, can you please explain to our audience how menses are correlated with migraines, and what is the impact of menstrual migraine on quality of life and social integration for a young adult?
Yeah, so as I said before, that probably after stress, menstruation is one of the most potent triggers for migraine in a young woman, and usually it happens in the initial few days of the migraine. And I don't know about the Western experience. I may be corrected, but in India, the patients I've seen, despite this strong association, patients usually do not come out with this history. You have to ask really that, does your menstruation trigger your headaches? And then they will say, yes, they will. And in India, it's slightly difficult, culturally speaking, to discuss about menstruation and, the other aspects of reproductive life to the patients, female patients, many a times, right? But nevertheless, in a clinic like ours, where we see a lot of patients every day, if in the clinic, we find that this is a strong association between the menstruation and the migraine. And as I said, that mostly they are the migraine patients in whom during the menstruation, the attacks increases. The pure menstrual migraine patients are much, much less in number. But the problem comes that menstruation itself is a challenging time. During the menstrual cycle itself is a challenging time for most of these females, especially in India, where people, women actually have a dual hit. They have to work at home, they have to work outside, and then they have this menstruation. So in that case, when they also have a migraine attack during that period, they are actually very miserable, and they actually face it very badly, and many of them actually cannot work properly. They have their social engagements fall apart. Their household activities get affected. Many of these mothers, they actually teach their children. And I have had the occasion of, listening to this complaint that they cannot really take care of the children during that time, and they feel awful about it. So that's important. And of course, along with that, there are other symptoms like, the pelvic pain, the cramps, the body aches, a general malaise, all these things start creeping up, and they add on to this, the problem of migraine during that time. So during that time, therefore, I think what to do about that. The patients ask, how do you take care of that, right? We used to have this, short-term prophylactics to cover that period, oral periods, but it's difficult to keep a tab on that, and you have to be exact. And many a times, even for say triptans, for example, some of the triptans were not easily available that act on during this period. So I think the neuromodulation device has another advantage during this period, right? They will be, kind of in a better position to actually take care of these patients during that time. And among them, I think the recently some of the neuromodulation devices have actually looked at this subpopulation, these people with a specific problem. And then, for example, this REN device, for example, they have looked at these patients, and they found that about more than 70% of them actually are liking the device during that, and they're getting benefit out of it. And that's a great hope for us, because if we can actually make them make their quality of life better, and they start working and they feel much better during that time, and that will be a great asset for the clinician. And I think at the end of the day, we all are here because we treat our patients, we care for our patients, and we want our patients to be well. So I think that's a very important thing that happens. And therefore, I think it's a complex issue. And then there are issues of, the young women in our Indian society, for example. Now they have taken a lot of jobs, like executive jobs with the night shifts, they're very, very challenging jobs. And during that time, they don't want to be in bed, with pain and this kind of a disability. So I think the neuromodulation devices, especially this REN device, because I think that as Professor Gosby has said, that we have now the data, an option to choose that, which agent or which particular modality we can use for a particular patient, and we can have an open discussion about it. And that's a great thing. Say about 20 years back, we didn't have this option. Now we have these options of a range of products that are available. So I think that's a great thing.
I see. Thank you so much, Dr. Chaudhary. And speaking about patients, we are also joined by two patients, maybe for now, since the topic that you touched based upon. So we would request Ms. Sarkar to maybe open up your microphone. If you're comfortable sharing your camera as well, please do go ahead. And for the other patients who have joined us, can you talk about how migraine impacted your life? Ms. Sarkar, if you're able to hear me.
Hello, can you hear me?
Yes, we can. We can.
Okay, so basically, I would like to share my experience that I had with migraine. So uh, last year, I started having very bad headaches, and I had no idea that what headaches I was having. So I kept taking painkillers, and I thought that it was normal random headaches. And then when it started getting out of control, my family doctor recommended me that I should go and see a neurologist because it could be something serious. Then I went to a neurologist, and then I got to know that I have chronic migraine. And it was honestly not very surprising to me because migraine is a part of my family history. Like my mother and my twin sister, they both had migraine from a pretty long time. So I was not shocked, but I treated it very lightly because I have been seeing my twin sister having migraine since the age of almost 10 or 12 years old. And she never had like major problem with migraine. Like she had episodic migraine once or twice, maybe like in 2 months. So she had painkillers and it made her feel okay. So I thought maybe that's the same that's gonna happen with me. I'll have episodic migraine, but it started getting worse for me. Like as my doctor mentioned that I had chronic migraine, I started having migraine attacks almost every single day. And I can't begin to explain like how bad the migraine attacks were. And there were definitely other symptoms present. Like I had a sensitivity to light, sensitivity to noise, and nausea was definitely there. And my doctor prescribed me a lot of medicines. Like I was already taking 7 to 8 medicines a day just for migraine. And at that point, I was also taking different medications because of some other conditions that I had. As the doctors were also saying about a lot of thing about how menstruation in women also had an impact on migraine. So I would like to say that I also have PCOS. So I was also taking PCOS medications along with this migraine medication. Then I took those medications for almost a year, but nothing changed. Those migraine attacks didn't um, like decreased or anything. It kept happening for a year. Then my doctor suggested me that as you are so young, like I'm just 22, and at this age you should not be this much dependent on drugs. So then he advised me the neuromodulation device, and I started using it. And I've been using it for 2 3 months now, and it had really decreased my migraine attacks. Like now I don't get migraine attacks frequently. I get migraine attack only when there is like any trigger point, like when I go out in the sun. Like sunlight is a major trigger point for migraine. So when I go out in the sun, maybe I have a migraine attack, or when I skip meals or something, or when I am in like a major stress or something, then only I get migraine attack. Otherwise, in an everyday basis, I don't really get any migraine attack. So I would say that the neuromodulation device really saved me from those painful attacks.
Thank you, Ms. Sarkar. Thank you for sharing your story. And at the
And
same time,
also, I'd like to say that my dietitian, Shri Porna ma'am, she also advised me a lot how to use the neuromodulation device and everything. So I would like to thank her also.
thank you, Ms. Sarkar. We wish you good health and hope you get well soon. You're already doing better. That's encouraging for us to hear. But at the same time, we wish you good health. Thank you, Ms. Sarkar. Moving on, maybe if I would go next to Dr. Pozo Rosej. Dr. Pozo Rosej, we understand that women is the pillar to family, and unfortunately, women are the most affected with migraine. One of the most desired emotion for a woman is the emotion of motherhood. How does migraine impact a woman from fulfilling this desire to plan a family? And can a woman suffering with migraine consider planning a family or planning a pregnancy? If yes, then when and what? What guidance would you like to share with our audience?
Well, indeed, becoming a mother is something that many women want to, not everyone. Also, I think it's important to mention it doesn't have to happen, but if a woman wants to become a mother, there's always kind of a bit of stress sometimes around it, especially if you have migraine. The first, I think, concern comes from the fact that you can inherit migraine. And that sometimes raises questions in the outpatient clinic. What we can say is that, yes, I mean, there is, of course, a risk that your child, whoever, boy or girl, might inherit migraine, but, it doesn't have to be with the same strength or the same frequency as you have. The migraine field is constantly evolving. We are talking now, for example, about neuromodulation, and there will be other things that in the future will help us better modulate and control the disease for sure. So usually that concern the person that wants to become a mother eventually, I don't think is too concerned about it, but that might raise a question. The second thing is that pregnancies, there is, I think, good news in the sense that usually during pregnancy, migraine attacks just naturally get controlled. And of course, when we say this is a very broad concept. That usually does not happen during the first term, which is a term where there are more risks of having, if you take certain medications, fetal growth problems, you could say, and congenital malformations. But indeed, during the second and third term, and even sometimes if there is breastfeeding, migraine can get actually pretty under control because, as Dr. Chowdhury was mentioning, suddenly you stop having regular cyclic changes of your hormones, and it's more of a plateau of progesterone and other hormones, oxytocin, that are actually in control and quite flat during the second and third terms, and that usually helps. Where I personally have experience on seeing more migraine attacks during the second and third term are sometimes related to stress, but that can or cannot be related indeed itself to the pregnancy, but if they're stress related. However, as I said, many that might be hearing this might have the experience of not having improved in frequency of their migraine attacks during pregnancy. And indeed, we need to be able to offer other therapeutic and possible solutions. So I agree with what has already been said, that neuromodulation techniques are something, to be offered, which is safe and effective. So by that, what I'm trying to say is that it is an option that we can offer, to patients nowadays. Before, when we didn't have this option, we can, at least in our country, we can offer patients triptans for the moment of the attack, especially sumatriptan, which has been around in the market for more than 30 years. And that for the attack is quite safe. And in prevention, it is very hard to treat the first term, but for the second and third term, sometimes we can offer other types of treatments if the ones I was mentioning don't work. And finally, we can also offer some anesthetic blocks, which are a bit, invasive. And with using anesthetics, you can actually try to block a little all of the pain that is happening at one specific time point. It doesn't serve too well to prevent attacks, but if a person, for example, comes into the emergency room with an attack during pregnancy, that is something we can offer, especially only with lidocaine. So I don't know. Yeah, I think it is something to consider. I think that for many women, it is hard to choose when to get pregnant. I would probably say, of course, it is better if the disease is controlled, but I would, go for it if mentally that's what the body kind of is asking from you.
I see. Thank you. Thank you so much, Dr. Rosesh. My next question is to Dr. Gaul. Dr. Gaul, what has been reported is that migraine peaks in the late 30s and perhaps early 40s. During the same period, physiologically, women is also undergoing menopausal transition, which is again another crucial time period in her lifespan, as she goes through the hormonal fluctuations, which results in mood changes, weight gain, hot flashes. Many patients around or post-menopause or post-surgical menopause, they have to use these oral hormonal contraceptives to manage these symptoms. And some of the current treatment options aggravate these perimenopause symptoms such as weight gain, whereas others are associated with potentially higher risk of cerebral or cardiovascular diseases, especially when they are used in combination with oral contraceptives. So how do these current treatment options interact with the fluctuating levels of hormone, menopause symptoms, and cardiovascular risk factors in women with migraine, particularly of this age group? And how do you see the role of neuromodulation for these clinical settings? Dr. Karl, you're on mute.
Yeah.
Now we can hear you.
You have still explained some of the important points. My patients report due to the hormonal fluctuations, for them, the migraines get unpredictable. If they have a menstrual migraine, they usually know, I can expect the next migraine in 10 days, for example, and they can be prepared with medication to look what to do, which appointments could to skip at these days. But if the frequency fluctuate very much, that's difficult for them. That's one point. The other point is we have no explicit approved medication for this situation. There is no medication approved for treatment of menstrual migraine or of these hormonal changes. And then we have the point that when they treated with hormones, it increased the cardiovascular risk, which is increased in patients with migraine with aura. And then if they have additional risk factors like hormonal treatments, contraception, that's really important. And at the same time, the patients get a little bit older. So part of the patients get hypertension and another cerebrovascular risk factors. That's the difficulties in this situation. And therefore, we have to look to alternative treatments. And I think the neuromodulation is a very good idea because we have no side effects in nearly all of the patients. It can be used as prophylactic and in the acute treatment. So they have all the options to use it, maybe using only to this phase of hormonal changes, and it can improve then. That's really good for the patient. I think this is a difficult situation in life due to the points you mentioned before, and therefore they try to do a lot of things. And we have, with the neuromodulation, we have no interaction with other medications which the patient has to take for diseases, or if they need hormonal treatments to manage the situation, we have no additional interaction due to neuromodulation. So I think it's, especially for this difficult lifespan, it's a good idea to try it.
I see, Dr. Kaul. And we are once again thankful to Ms. Schnellen for joining us for this webinar as a patient's voice. Ms. Schnellen, you've heard some of the comments from our experts on the board, but at the same time, what patients would be interesting to hear is how has been your journey with migraine? How did it impacted your life? And if you're comfortable sharing in your words, please do go ahead.
Good afternoon from Germany, and thank you for inviting. Since elementary school, I have repeatedly suffered from migraine attacks with nausea and vomiting. With the onset of puberty, the frequency increased with the onset of my period. During the pregnancy and birth of our 3 children, the symptoms were rather regressive and rare. However, the migraine attacks increased again with the onset of my menopause, usually occurring once a week. After trying several therapies, beta blocker were not an option due to my tendency towards low blood pressure. Flunarizine showed no effect, and various triptans were also ineffective. I found that naratriptan works quite well for me. If naratriptan does not help, I'm unfortunately forced to endure the feeling of having a claw around my head until it often releases after 2 days. The accompanying symptoms were extremely sensitivity to light, photophobia, smells and sounds, phonophobia, as well as severe vomiting and, above all, intensive left side headaches. Stress and weather changes are possible trigger mechanism. Through the flyer of Nerivio from Dr.Reddy's, I came across this non-medication therapy. Since July of this year, I initially tested Nerivio, but due to its good tolerability, I have now become a frequent user. Since then, my impression is that the frequency of migraines has decreased. However, even after using it and then taking a tablet, I believe that the migraines no longer reach such extreme peaks. I would also like to positively note that Nerivio is easy to use and well tolerated, and I always receive quick support from Dr. Reddy if I have any questions. My concern is to help other people with my contribution. Thank you very much.
Thank you very much, Ms. Schnellen. So we go over to next or the last section for the day, and then we just take a couple of questions. We are already over time. We go over to Dr. Huth. Dr. Huth, what are your thoughts? How relevant are the interactions between migraine medications and medications that are being used to manage other illnesses that are generally seen in women above the age of 45 or 50? What are your thoughts, and how do you see these drug-free solutions or neuromodulation approaches benefit such patients?
Okay, great question, Dr. Singh. We spoke earlier a bit about the younger set of patients, and that group is usually not on other chronic medications because they don't usually pick up chronic disease. But once you get to a certain age in life, most people pick up some type of illnesses or diseases, and they're on chronic medication. Now you take migraine medication, you put that into the body, and then not only do you have a chance of adverse effects or side effects from the migraine medication, but you have a chance of interactions between the migraine medication and the other chronic medication. And this can take various forms. I spoke earlier a bit about risk versus benefit. And really what can happen in the situation is that you can have the migraine medication become less effective, and therefore you get less benefit from the migraine medication. You can also have the migraine medication make the chronic medication from what other condition less effective and less benefit from that medication. And then you can have the risk of either also being increased. So the migraine medication goes in and makes the other medication more likely to cause side effects, or the other medication makes the migraine medication more likely to have side effects. So it's a bit of a complicated way of discussing it. But what I try to explain to patients is that, you know, the more migraine specific we can get a medication to be, the less chance of adverse effects and of interactions. So really, we have a lot of medications we use for migraine, for example, in prevention, that are used off-label, and they were initially designed for other diseases. And we know that they have benefit in migraine, so we do use them. But they do come along with a lot of adverse effects and also interactions. So one has to be quite careful. Let me give you some examples, maybe just to make this a little bit more real for you. So for example, if one takes non-steroidals for acute, abortive treatment of migraine, one has to be careful if a patient might be on an anticoagulant in that age group. What happens if somebody is, for example, taking a calcium channel blocker such as verapamil, which we use quite often in migraine prevention? Sometimes that can interact with statins for cholesterol, increasing the risk of statin-related side effects and muscle cramps and increasing liver enzymes. And then there are lots of different migraine prevention medications that affect the liver's enzymes. The liver metabolizes medications. So they affect the what's called the cytochrome P system, all these different enzymes in the liver that break down and metabolize drugs. Those can be affected by a whole host of the different migraine preventers. And that could be increasing the enzyme to break down the medication too quickly, or stopping the enzyme from breaking down medications, which means you might have a sort of overdose type of situation in the body. And you asked me about neuromodulation in terms of this as a sort of solution to the problem. So of course, patients, when they take an oral medication, they understand something is going into their body and systemically is going to affect them, whether it be through an adverse effect or interact with other drugs that are in the body at the same time. When we talk about neuromodulation, we are attaching a device to the body that is impacting externally, usually on the nervous system. And really, it does not have that same type of interaction with other medications. So you're kind of taking away all those risks we spoke about of, one, it making other medications, chronic medications, more dangerous for you, or impacting their efficacy and making them less effective. You're taking that away, but you're also not having any effect from the actual chronic medication on your treatment of your migraine. So it really takes that whole equation and makes it very suitable and very positive for the patient.
I see. So Thank you very much, Dr. Huth. And I would also like to thank very much to all the panelists for sharing their thoughts during the panel discussion. It was an exciting conversation. We are slightly over time, but what we'll do is we'll take 2 questions. There are several in the chat box along with comments as well, but in the interest of time, we'll just take 2 questions. And perhaps for the first question, if I would request Dr. Goodspeed to respond to that. And for the second question, I would again request Dr. Goodspeed to nominate who could respond to the second question. So, Dr. Goodspeed, the question here that I see in the chat box is from a 25-year-old patient who says, I suffered 25 years of my life. I lost all battles, could not got success in my judicial exams. I was so brilliant student. I used to ask God every day, why me? Why I suffered severe migraine. And the other question, the second one is there any research about the association of food and migraine? So the first question, if you could take that up, and for the second question, if you could nominate a panelist.
Well, to the first question, I'm sorry to hear all the problems that you've had with your migraine. I wish I could tell you why we think migraine, as has been said, is largely a problem that's fundamentally inherited. Why you might have got those genes is not clear. Clearly, a female, if I understood, is more at risk because of the hormonal things that Dr. Chowdhury explained. I think that as well as asking why you, what I'd say is, why couldn't we do better? I think the substance of what we've been talking about in this webinar is to make sure that the advances that we've had in treatment and understanding of migraine in the last 20 years or so are better distributed. And perhaps the biggest problem that you illustrate is the failure of the system to get the diagnosis, get the management, to be able to help you with the problem. While we're working out why you, we can do better with how you, so to speak, how well you can do. Now, in terms of food triggers, I'm sure all of my colleagues would love to take that question on. So I'll just okay. So some less than others, it would seem. Let me ask Dr. Huth if he wants to comment about. We all mentioned you've been talking about children and such things. So perhaps food triggers.
Yeah. So I think generally when we look at
Doctor, before you start responding, sorry, Ms. Schnellen, may I request you to please mute your microphone? We're hearing background noises. Sorry, Dr. Huth, for this interruption.
No problem. Okay, so sorry to also hear about that patient's struggles. Obviously, our hearts go out to them. That often a lot of people that are not in the migraine world underestimate the impairment and disability that go with migraine. And even my colleagues as neurologists in South Africa, I have to keep reminding them and reminding insurance funders and everybody else of the disability that goes with migraine. And, on a really bad, severe migraine day, a patient is bedbound. And therefore, it's equivalent disability as somebody who may be quadriplegic. You cannot function. You cannot go to work. You cannot interact as a spouse. You cannot interact as a parent. It's really quite a disabling disease in many patients. So yes, I empathize and sympathize with the patient's problems. In terms of the food triggers, there are certain classic food triggers over the history of migraine that are thought in some patients to trigger migraines, and there are sort of general concepts related to food and hydration in terms of lack of hydration or using too much caffeine or being dehydrated, leading to a lower threshold for having a migraine. What's important, I think, to consider when talking about triggers is that it's not always about avoidance of triggers, but it's really an avoidance of fluctuation in triggers in terms of how much fluctuation you have, for example, in your coffee intake or in your hydration status or in types of foods you eat or eating patterns and eating and when you eat and if you skip meals, etc., etc. So a lot of the thought around triggers moves away from avoidance to actually just maintaining status quo and stabilizing exposure to triggers. And I really would advise the use of a migraine diary. And there are lots of excellent apps that you can get on cell phones, for example, Migraine Buddy, etc., that can help you to identify triggers, both those that are external and internal, and ones that are related, for example, to meal patterns or eating certain foods. It's very important to take that exercise early on and to decide whether you think there is a specific type of food substance, such as alcohol, caffeine, certain types of cheeses or containing certain types of amino acids, or for example, are you sensitive to sugar or gluten, etc.? Does it have any impact on your migraines? And you only be able to get that data by actually exploring your environment and how you react to these certain foods. But basic lifestyle of not skipping meals, regular hydration, etc., is important in terms of food and drink.
Thank you so much, Dr. Ruth. I see several questions still coming in our YouTube page chat box, but in the interest of time, we have to wrap this session up. The questions are once again. Yes.
Can I just add just a small statement, because the question was also on the research. I think Professor Goatsby would be interested, and he would be spearheading this research that now a lot of gut and brain axis disorders have been described, especially the degenerative ones, as stroke and also migraine. I see a few new papers on gut microbiome and migraine. So I think Professor Goatsby, as always, the pioneer in picking up the newer things. So he must be thinking about some studies on that.
Thank you very much, Dr. Chaudhary, for your comment. And I would like to thank all the panelists and especially for the audience as well to join in. Maybe if we go over to Dr. Goatsby for the closing remarks. Over to you, sir.
Well, thanks, Dr. Singh, and indeed thanks to the audience for coming along to this. Migraine's very common. Millions of people are affected. The attacks are disabling. It's primarily a disorder of the brain, which we're starting to understand. We've developed better medicines and neuromodulation approaches that are effective and they're well tolerated. What we need to do is make sure that the right people get the diagnosis and that the treatments are better distributed. And I think both of the patient histories illustrate that problem. With that said, our understanding is imperfect. We're not capable of controlling everyone, and we've got much to do for many. We need to redouble our efforts at diagnosis and treatment. All that said, I'm optimistic for the future. As we make these new treatments available, many more people will benefit. We've got much to do. Be sure all of us on the call are dedicated to making the world better for migraine, and I thank my colleagues for joining the call. It's been a pleasure to be on the webinar with you, and I thank Dr. Reddy for making the opportunity for us. Thank you.
Thank you very much. Thank you so much. Wishing all the patients very good health. Thank you. Thank you so much. Okay, I think we can log off. Thank you very much. Thank you. Thank you.
Thank you. Bye.